I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And I am delighted, excited really, to have as our guest today, Chris Habig. He is the founder and CEO of Freedom HealthWorks. He's also been for at least the last 4 years, we were trying to nail down exactly how long, the host of the annual Free Market Medicine Association conference, which this year was in Oklahoma City again. And then he's also the host of the Healthcare Americana podcast, which is sponsored by the Free Market Medical Association. And Chris, you do all kinds of other stuff too. Welcome to the show.
I appreciate that. I'm trying. I think you got everything for the most part. We also started our own clinical network of direct care practices, just to give doctors another option. We're trying our darnest to get as many physicians into this line of thinking and this line of practicing medicine as we possibly can.
Sure. So now, as you know, our target audience here, our main audience is medical students, residents, fellows, people who are in training or people who are fresh out of training. But we've got a lot of other people that are watching and listening to the show as well who have some kind of interest in healthcare. And when we talk about giving doctors other options, it makes it sound like, the system that they're currently in or whatever situation they find themselves in may not be so palatable. So what is it about our current healthcare system that makes doctors want to look for other options?
I think it's they've been pushed to the brink. I think there's a lot of medical students, a lot of residents out there that say, you know what, I got into medicine to help people. I didn't get into medicine necessarily to become rich or all the prestige that goes with. I am a truly empathetic person, and most of physicians these days are very empathetic. They're very educated. They're very intelligent people. Not all of us can do that, right? I was pre-med back in undergrad, right when the ACA was passed. I took a look at medicine. I'm like, I don't think I want to do that, because it felt like we were just training physicians to be a funnel for large hospital employers. And it didn't used to be that way. So I was raised by a 2-physician household, blessed with that, both of them independent. Mom was an internist, dad was a family doctor. And so I saw firsthand kind of the challenges of independent practice on your own, and then the benefits of it, obviously, too. A great family structure. But I as I got older and started looking and saying, do I want to do a career in medicine, kind of follow the family business, there wasn't a physician that I had met who said, hey, medicine's a good idea right now. And there wasn't a physician who said, if I had a second chance to go back in time and redo it, that they would go back into medicine. And I'm like, okay, that's pretty powerful, right? And I said, why? And they're like, well, all medical schools are doing are partnering with these teaching hospitals, residencies, and they're just funneling people into employership, into it as employees. And they don't even talk about what independent practice looks like. And for thousands of years, since the term physician was first coined as, ancient teachers, it was independent, right? Like, this is that trusted person to do what is best for their patient. And now there's such a massive conflict of interest that it's refreshing to see med students and residents and these younger physicians who we desperately need to take care of their communities. It's great to look at it and say, well, why is that my only option? Why is my only option signing the first, hospital contract that's put out in front of me? There has to be a different way. I don't want to practice like that. I don't want to live like that, because they can see the damage that it's done on, mid to late career physicians, and say, there's got to be a different way. And that's what's exciting. That's what really excites me when I see all these doom and gloom reports about physician shortages, all this kind of stuff. I'm like, you know what? For the first time ever, like within direct care, specialists are now jealous of what the primary care doctors are doing. And that doesn't mean the specialists can't do it. We're working with them, but kind of a long answer to a short question there, Doc. Like, I think these smart students and smart residents who want to help communities are waking up and saying, I want to help them, but I don't want to do it that way, because that way is more harmful than what I know in my heart I should be doing.
Sure. So, in my conversations with medical students recently, and with residents, and even to some extent with fellows, there seems to have been a shift over the last, I don't know, 10 years or so. And I hear medical students talking about how uh, being a physician is kind of a stepping stone for them. And they're like, well, I can't practice medicine forever, not like the older generations have done, not like you've done. Because I just know I'm going to get burnt out. I'd love to be able to do it, but I don't see a path forward. Is that something you've run across also in working with with trainees and people who are fresh out of training?
Yeah, and honestly, we don't work with a lot of the physicians that think that way. If you're a doctor and you're like, "Hey, my career path is to get my MD, and then I, want to practice for a little bit, and then I want to get an MBA so I can move into hospital administration and and be a CMO." You know what? Great. If that's what really makes you happy and that's what you want to do, awesome. One of my favorite questions to ask those people is what does a chief medical officer actually do? And the ones that have been a CMO before, they're the ones who are actually honest about that answer. And this is an actual conversation I had with the chief medical officer of a hospital, big hospital group here in Indianapolis. And I go, what do you actually do? And he's like, well, I liaise, between our administration and our medical staff, and I make sure that our physicians are happy, and I make sure they're hitting their quality metrics and all this kind of stuff, like jargon, right? Just buzzwords.
Sure.
And I said, well, Doc, how do you define quality? And it felt like this one finally like kind of pierced the veil. He laughed and kind of sat back and took a sip of his coffee and said, Chris, quality to me right now is whatever the heck Anthem tells me it is. And Anthem's changed names since that conversation, but I can still pick on him as a boogeyman.
Sure.
It's whatever Anthem tells us it is. It's whatever Medicare tells us it is. And I go, I try to kind of stifle a laugh, and I wasn't trying to play gotcha. I'm generally curious, what that answer is, because I didn't know. We had recently started Freedom HealthWorks, and I'm trying to learn as much as possible. And for him to be that honest, that a quality metric, whatever we do, is whatever the insurance company tells us will maximize our revenue. That to me is the definition of what a chief medical officer is actually supposed to do. And that's
Sure.
scary. That's scary. I have a family. And so I'm like, you know what? Are my best interests always going to be represented by people who want to be MDs and then move up into hospital administration, knowing that they look at us and say, how could we get as many CPT codes out of these people as we possibly can? There's a massive conflict of interest.
Right.
So again, if you want to go to medical school and go that route, I wish you all the luck, but it's kind of sad that that's seen as the dream career path for physicians these days.
Yeah. I've run across a few people like that, but it's been my experience that the majority of the people who say they want to do something else after medicine are the people who are saying, I really like the idea of providing care for people and making them better, but I just know that the system's going to burn me out and I don't have any hope. And so there's a sense of despair that I hear in these medical students and in these residents. And it seems to me that the work that you're doing with Freedom HealthWorks might be an antidote to that.
I hope so. So what we do is we try to be kind of an all-inclusive startup solution, and then help them run their practices as efficiently as they possibly can. Very much centered on that pure membership model, right? So as the language and terminology evolves, whether it's direct primary care or you move into direct care, and you get a lot of different non-primary specialties involved in that. Starting a business this day and age is very, very hard. So our mission is really to be able to return as many physicians into independent practice as we possibly can, and be the enabling asset to be able to do that for them. That doesn't mean that we just customize everything. We have a program that takes about 4 to 6 months that is quite successful. We have a 98% success rate right now, which means 98% of the doctors we've worked with in the last 10 years are still in business, still practicing. We can count our failures pretty much on 2 hands, basically, and we know exactly what went wrong on that one. And sometimes business ownership's not for everybody, and I think people understand that if everybody was a business owner out there, it'd be a really interesting world. But But yeah, that's what we've been doing for 10 years, is taking a physician who says, I want to go be my own independent physician. I don't want to deal with insurance. I don't want to deal with administration anymore. Will you guys help me make that journey? And we say, yeah, absolutely. So like I said, a 4 to 6 month process. We pretty much do everything for you. We still need your blessing on a lot of things and a lot of your input. But the vast majority of our clients that we work with, are kind of mid-career physicians right now. And so they're working in their hospital, and then we're helping them start a practice in the background. So there's no income interruption. They can kind of step out of their hospital employment on a Friday and step into a brand new practice on a Monday. And that's kind of the magic in it. And then we help them run their practice. They don't have to hire a bunch of people right away, and try to keep those costs as low as possible while building a solid foundation. I tell people all the time, like, do you need to use us to build a practice? No, you absolutely don't. But I think the smart ones do.
Sure. So tell us about the genesis of Freedom HealthWorks. Like what prompted you and your collaborators to finally decide, you know what, let's just do this?
It's again a very like family-oriented personal story. I mentioned my folks a little earlier in our chat, and it finally came to a point about 10 years ago where their private independent physician group was looking at selling to Optum. And like everybody, I could hear all the listeners just kind of cringe right there when I said that. And I think people understand where I'm going with this one. And I think my parents at that point were mid to late 60s, still had a lot of career left in them, and you look at career arcs of physicians, and most physicians peak later on than what typical white collar professionals do, because it's a practice, right? You're learning, your experience, and you get to build on all that knowledge. And so as you get older, you can reach back and say, wow, I saw this case 20 years ago. Here's how we handled it. Maybe the same. Anyways, and so they said, we don't want to go work for insurance again. This doesn't make sense for us. We're just going to retire. And so my dad was the first primary care physician in a town north of Indianapolis. He'd been there for 4 decades, I think. My mom helped start a hospitalist program in a neighboring county. They're kind of institutions up there. And so they took us out to dinner, and my siblings and I, and said, hey, we're going to retire. And we're like, why? Why? They always threatened us to just hang a shingle and charge people $200 or $100, whatever it is, or a carton of eggs or a case of beer, and come see them. They said, why don't you guys do that? And I remember them saying, well, I don't think it's legal to see patients, without taking insurance. And we're like, interesting. So we were always kind of like working on this side over here. We had some different type of medical companies and ideas, mostly focused in medical tech. And we're like, you know what, screw that. Our specialties, our skills are more oriented towards embracing that entrepreneurship, but giving people a steady program, a steady path to follow. Again, it's not rigid. My job, if I'm trying to teach you how to ride a bike, my job's not to keep you from falling off the bike. My job is to keep you from riding your bike off a cliff. That is what I want to avoid, is the business killing mistakes that we see doctors make, any business person make. And so that was kind of this. We're like, well, here's what we're working on. Would this be of interest to you? Because we were about to go raise money and do all this kind of stuff. And so they're like, are you kidding me? Like I can flip over to, at that point, it was like concierge, right? Sure. And concierge at that point meant hybrid and membership. And they're like, you mean I can just do membership alone? I don't have to do anything with third party? And we're like, yeah, people are doing it. I don't think everybody's doing it really well right now. And so we were able to kind of pick and choose which pieces of different models that work the best from interviews and doctors all over the country. We talked to people who are just doing hourly. We talked to people who are doing big annual retainer fees. We talked to people who are doing visit fees, people who weren't doing visit fees. And so we kind of found this right type of model that would work for this area. And we just started fielding phone calls from physicians who said, hey, I heard about what this practice is doing. I know you guys helped them do that. Will you help me do it? And things just kind of snowballed from there. And so, currently we've helped about 160, 170 practices across 40 some states. We're very selective about who we work with. If you call us up and say, hey, Chris, I want to be the CEO of this new physician group I'm starting, I'm going to say, we're probably not the right shop for you. If you call us up and say, hey, I want to do a hybrid and accept Medicare, okay, but we're kind of purists when it gets in that one. So, yeah, it was kind of this springboard, and sometimes, I'll end my answer with this. Like sometimes that idea kind of hits you in the face like a wet newspaper on a windy day, and you just cannot get around it. And we're thinking, why don't more doctors do this? And we found out that that biggest hurdle wasn't the why. Every doctor knows why. It was the how. And
Right.
so we became the platform where we say, you know what, we answer the how. We're the answer to that how question. How do I get back into independent medicine? And how do I make primary care a profitable business where I don't need a hospital to subsidize me?
Right. I am so excited that you brought up this idea of whether or not a direct care model is legal, because I'll tell you, in my practice, it doesn't happen as much now. But a few years ago, I was shocked at how many patients would call and say, "Wait a minute, you do what? You don't do anything with insurance? I mean, is that even legal? You guys might get yourselves in trouble." And then we actually had a couple of, potential patients who called up and said, "I'm going to report you guys to the insurance commissioner of the state." And I said, "Well, go right ahead. I want him to know about it too, because maybe he'll become one of our patients." But can you speak to that a little bit? Like there's this myth about whether or not direct care is legal.
Yeah. Yeah. Every state's a little bit different. I will say that there are some hoops that some states will make their physicians jump through, and you just have to be aware of it, right? And I will say, for our listeners out there, be weary of anybody who's trying to give you legal advice in all 50 states at one point if they're not part of a larger firm. And because that could be, kind of scary. Like if you read something online, like it's probably not good enough if you ever do get challenged on it. You want to make sure that if you do seek legal advice, like you have something where they will stand behind that. There have been DPC laws being passed all over the country. We were very active in Indiana, and we still are, at the state house to make sure that there's no unintended consequences of any type of legislation, right? It's kind of the bane of government is they think they have a good idea, and there's always the fallout goes a different way. So we try to minimize the impact and actually open up markets. We saw a lot of legislation being written around the country that would box DPC in and be like, if for direct primary care to qualify, you have to do boom, 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 this kind of stuff. And we said, no, that's garbage legislation. We want to open it up. We want legislation that says, if you accept memberships then and provide medical service, you are not part of insurance regulation, like rather than trying to define something. Because as you can see, kind of what you're talking about, like there's a lot of surgeons, there's a lot of specialists who are starting to look at this and say, how do I build this? And now we have to go back and look at a lot of those bad primary care laws and revise them so that opens up for specialty. We just ran across this in Georgia. Everything's written for primary care, this, primary care, that. And now we're like, you know what, whoever put those laws into it, great first step, but you didn't go far enough, or actually you kind of did a disservice over here. That's kind of it's kind of a tangent there. But when it comes to the legality of it, that's why we say, look, we need to sideline Medicare, CMS. We need to cancel any type of commercial insurance, because that's where, people confuse legality with contracts. It's not illegal for doctors not to accept insurance, but if they have a contract, they need to honor that contract with the insurance companies. So a little bit different. They're not going to jail by any means, but they could still get sued for that. The U.S. was set up as 50 different experiments, over time, and they still are. There's no big binding legislation of what this is, but you definitely want to be aware of it. Every time we start up a practice, we do a state legal review. I don't care if we just set up a practice in Missouri and we get one a month later, we're still going to do a legal review, because that's how quickly things can change from agency law into actual legislation. So we're right on the forefront in making sure people do that. For an example, in Pennsylvania, you don't want to bill at the beginning of the month, you want to bill at the end of the month, so it doesn't look like a prepaid health plan. That's where the insurance regulators are going to get you if they ever took a big, hard look. So there's always this little nuances in states. Pretty much of them, they fall in a couple of different buckets, and we're pretty good at being able to attack those. But you don't want to just blindly set up any business anywhere. I tell people all the time, I wouldn't set up a hot dog cart in downtown Indianapolis without doing my homework, and doing my homework very well, and asking for help. I think that's the biggest thing that leads to a lot of failures within independent medicine, is that people think that hey, I got through medical school, so I can do this all myself. Some can, and that's great, but the majority of us cannot start any business on our own. We have to ask people who've done it or have, some type of advisory function on there. So it's always okay to ask for help. And I just, I think that's like one of the big takeaways, that I always tell people, like, as a doctor, it is okay to ask for help. I know you're usually the one that has to have all the answers, kind of the buck stops here mentality, but you can ask for help and you should.
Sure, sure. So you had mentioned earlier, that you have a very high success rate, but you've had a few failures. What lessons did you learn from those failures?
You got to be able to talk to patients and convince them why they should join your practice. The physicians who were not successful in this model, in hindsight, like we probably shouldn't have done business with them. We should have caught this earlier. So kind of on us. I'm not pointing fingers by any means. The way we set this up is that, when that final like sales conversion has to happen, that has to be between a doctor and a patient. My team, so we have a sales team, right, that will talk to patients all day long for months and months, lead them through funnels. And so we make sure that no lead is ever missed and that every lead has text messages, emails, phone calls, voicemails. We set them up to come meet with you as a physician. If you cannot sit across from somebody and tell them why you should be their doctor, you're going to have a hard time.
Sure.
And that is just that. And I don't care. That's not picking on introverts. That's not picking on extroverts. That is just rehearsed. Like you have to practice what you're going to put in. If you don't have your value proposition down, you're not going to be successful. There were a couple of them that were just flat out dishonest with some of the debt and obligations and that kind of stuff. And their business started and they had way too much debt on the practice, or they just spent it very, very poorly. If you're looking at putting $250,000 into your furniture, into your office build out, that's a bad idea. And so, we don't really have the power of the purse. So we can tell people until we're blue in the face, like focus here, not there. But if they'll listen to us, then you know what, we're going to try our hardest to get them in a place that's good. But I would say, overall, like if you're a doctor and you're looking at this and you're not spending your time either growing your business, so business development, looking for new business, new dollars, meeting the community, meeting business leaders, meeting community groups, churches, that kind of thing, or you're not seeing patients, like spending time in the exam room, those are pretty much the only two things you should be spending your time on. You need to hire out or find somebody you trust to handle everything else, because that is where your value is, and that is where your time is well spent. So, like I said, there's a few reasons that stick out on why people were successful, but it's that final like sales plug. Like if you're not willing to knock on doors and go to meetings and talk about what you're doing, and why it's better for patient care, not just, hey, I'm doing this so that I'm happier as a physician. I'm doing this to take better care of my patients and better care of my community. If you can't talk about that, then you're going to struggle.
Sure. Now, contrast that with your greatest success story. Tell us about that.
Small towns. Small towns have absolute monopoly usually on patient care, and so we'll work with physicians who've been in the same area for 10 plus years. They flip that switch, and all of a sudden it's like day one, boom, you've got 300 patients, and it's like, oh, okay, now it's a different challenge. Now everybody is going to be calling you because they are full of bad habits, right? Most American healthcare consumers, if they need to be seen, they will be calling multiple days to try to get in. Now, when those practices open and they've got a couple hundred pre-enrolled, it's like a gold rush for the first week or two. And when that happens and it's open doors and you're seeing everybody, you're like, oh my gosh, I can't do this. I don't have the resources. I don't have the staff to be able to, churn people through. And what happens inevitably, they get through that first week and then they see their schedule start to open up because patients are now learning that the doctor is available. And you can see this kind of sigh of relief. But it's always those first 2 weeks after the doors open, when you're able to convert like an existing patient panel or people know you and they all come flocking to you. it's kind of like grabbing the bull by the horns and just kind of holding on for those 8 seconds. And then
Sure.
and then you're like, oh my gosh, here's the lifestyle. I get my Fridays off. I can see the kids during the evenings. I get my weekends back. That's always a very fun to just kind of sit there and we're the steady voice saying, Doc, look, I know it's busy right now. You have 300 people who aren't used to being able to text you or call you or see you in the same day or next day. Let them kind of catch their breath, and then you'll be able to go. Those are fun, but it
Sure.
is like everything we can do. Just be like, hey, this is coming. It's coming. You've been a very successful career. People know you in this area. This is what your next couple of weeks are going to look like. We're here to help you absorb that in the back, but you've got to be able to say, hey, patient, once you realize I'm here, you don't need to be seen right away. Like we can do a physical in a few months. It doesn't need to be right now. But it's just kind of the magic of it. And that is just fun to see because you're giving patients an option too, right? We talk about doctors having an option. Now patients have an option of how they experience care. And lo and behold, they want access to a trusted physician. And I think it's a beautiful thing.
Sure. So if I remember correctly, Freedom HealthWorks started with a focus on direct primary care, right? So, I mean, obviously over the last 10 years, you guys have evolved quite a bit. You really refined your model, refined the workflow. Can you think of a recent practice, a recent direct primary care practice that you guys helped start from scratch? And can you walk us through what that experience was like for them? Like they called you up or they emailed you, and from then until today.
Yeah, I mean, there's a lot. I'm trying to think, just
Just a
one.
typical one.
Yeah, just recently. If they call us up, whether they call and leave a voicemail, or most of them just come in through actual referrals right now, or you come in through our website. Our sales team calls you right back and kind of leads you through, hey, this is what it looks like. We work in 4 phases. So phase 1 is what we call our feasibility phase. We're going to go in there, we're going to research, we're going to do a market research report. So we know like what zip codes, what towns are best for this around you. Inevitably, recently we've gotten a bunch of people who saying, look, I'm thinking about these 2 towns, A or B. And so we can go in there, we run our demographics, we look at competition, we look at how people are spending their healthcare dollars. Public service announcement, like most of patients that join these practices are actually paying for things like gym memberships and massages. They're taking care of themselves already. That's a free tip out there for your audience if they're listening. That's who you target. So we do that. We also look at competition. We look at cost of living so that we're able to make location recommendations and we're able to make pricing recommendations. Those are the 2 biggest questions that I think any physician has that I hear a lot. I work with a lot of different outside groups just to try to get people where they need to go. Location and pricing are number 1, number 2 question that always come up. There's a fear of physicians of going out there and asking for money out of pocket in order to be in order for the service to be provided. And I tell them all the time, like, profit's a good thing. Profit is okay. Profit is what keeps you in business and keeps you seeing patients. It's great. So with that feasibility, we do the market research study. We do the legal matrix, like I talked about before. There's about 15 to 20 questions that we ask about each state that we want to make sure we have, on record of having in there. We look at budgets. We look at 3-year runouts of pro formas. And then, if you're going to be looking for a loan or anything like that, we'll put together a business plan that, we work with lenders day in, day out. If somebody's looking at bringing on extra capital for their practice, like we have resources for you and we know what they want to see. So that's phase 1, right? And we price that at $5,000. And there's no commitment to move on beyond that because we want to make sure that the physician is comfortable with where they need to go. These are the decisions that we need to make right now. This is the research. Let's make an educated step and say, do you want to continue on to phase 2? Phase 2, we're right at like $18,000, $19,000 in there. All these prices are on our website anyway, so I'm not just making stuff up. This is kind of where it happens. Like this is like the business building side of it. Some people say, well, Chris, at phase 1, I had these deliverable reports. Phase 2, you're just delivering me my business. I can't hold it, touch it, feel it. And it's true. This is kind of like that foundation. We need to make sure that all of your systems are set up. We need to make sure that all your vendors are set up. We need to make sure that your location is able to actually see people if you're doing brick and mortar. If you're doing virtual, probably need to do a lot more investment into marketing because you're going to be harder to find. And so that's where a lot of the magic happens. And that phase 2 takes up probably the good chunk of that probably 3 or 4 months of the launch process. Moving into phase 3, that's where we do a lot of our pre-enrollment marketing. We do a very extensive marketing campaign where our people are actually calling local groups, local businesses, setting up interviews, trying to get you in front of people to help spread the word. And we have a ton of success with it too. And so once all those things are clicking along, right? We have research, we're making decisions off of data, off of research from phase 1. We're building your business and putting all the systems together so you can accept dollars and see patients in phase 2. And then phase 3, we're telling the whole area about it, the whole community about it. That's when your practice opens. You start seeing patients. And then I mentioned 4 phases because phase 4 is where we look at this and say, all right, where are your challenge from a personnel standpoint? Do you need help answering phones? Do you need help running, pre-authorizations? Do you need help doing your books? Do you need help? Like where is the challenges that you're facing right now? And we usually have I'm talking fast, I know, but we usually have a pretty good idea of like what services we need to recommend. And so I think it's rare that we actually recommend all of our practice management services for a practice right out of the gates because they don't need it. Right. So if you're a practice just starting out and you're new to an area, we're going to say, look, you got to invest heavily in marketing. You don't need some of these other things back here that a mature practice would. Right. And vice versa. If you're a mature practice and your word of mouth is just snowballing downhill and you're getting a lot of people just from referrals, you don't need to spend a lot of money on marketing. So we like to work with the practices. I never want to get in a situation where a doctor's looking at us saying, hey, you're just taking my money and not providing value. I don't like that at all. So we don't have long-term contracts. If we're not doing a good job, then fire us. And that's fine. Do what's best for your business. We want long-term relationships, but we got to make sure we're providing value and doing a good service at the same time.
Of course. So that's kind of the roadmap for a direct primary care model. Now, I know that you've more recently started to dive into the direct specialty care market. How does that roadmap look different?
There's a lot of similarities. Again, and we focus kind of on the business side of it. The differences are going to be what type of services. That's when those legal questions start to come in. So Georgia, just to pick on Georgia because that's fresh in mind, their primary care law says that you can't charge a visit fee higher than your monthly membership fee. So if you're a specialty and you're doing like second consults or something on very complex, specialist cases, that's going to be a big problem if you fell within that law. Now we're able to build cash pay, specialists outside of the barriers of that. But again, that's why you need to understand what exactly you can and cannot do according to the state law. So there's just a difference in services and pricing, and then how you talk about that. Most specialist practices don't need as many patients, but a lot of it is more episodic or more package based. And so when you do your budgets and do your pro formas, you want to have a very good idea of what is going on in the market, what the cash pay prices are at the hospital, what kind of insurance, most of people have in there. Is it commercial insurance? What does that look like? Just so you can help really, really meet the market and pinpoint your pricing and services. Other than that, like a lot of the vendors are very similar. So it allows us to kind of change hats and move into it pretty seamlessly. The only thing that we don't really do right now are like surgery centers, like building out surgery suites. There's a whole different skill set, as you know full and well. And I don't know if we'll ever get there anytime soon, but we really like focusing really on the primary and then the non-primary specialties because that's really where those relationships are built. And we don't have to have a bunch of like surgery equipment or anything like that. It just, the costs go up from there. So again, with our mission of trying to get as many physicians into independent practice as possible, ideally using this, that's really where our bread and butter is from primary moving into specialty.
Sure. So then as far as specialties go, and I know I'm harping on this just a little bit, but I think it's partly because a lot of people out there are really familiar with direct primary care, at least a lot of our audience, and they may not be as familiar with direct specialty care because it's not as mature as direct primary care is. In my conversations with specialists, particularly with surgeons, a lot of them are very interested. Like you said, they know the why, and they might even have a sense of the how, but they often have a lot of the same. I don't know if you'd call them objections or obstacles that in their mind prevent them from finally squeezing the trigger. What have you found to be, particularly among the specialists, the biggest obstacles that make them hesitate and say, yeah, I know I should do this, but what about this or what about that? Or I can't do it because of this reason or that reason. What are the myths and how do you address them?
I think the biggest one is that they are very dependent on referrals. And when you're looking at this and saying, all right, where is my existing customer pipeline? If I leave my hospital system, what happens to that pipeline referrals? It's a question like that question's as old as time is, right? Like any business is like, great. Where are my new customers going to come from? And then the second one is, are they going to value my service when I ask them to pay out of pocket? It's a market question, where my customer is going to come from, and then it's a pricing question. Are they going to value this now that they can't just throw an insurance card down? In a perfect world, there's insurance. There's just as much disruption happening from a health plan standpoint. It's kind of catching up. I'm a big fan of health shares. We match our members and our patients up with health shares and, DPC as much as we possibly can. And it's a beautiful thing. I don't think anybody's had any issues at all, with reputable health shares and what's going on there. But from a specialist side of it, a lot of them don't know about health shares and they don't really make themselves available in the right type of groups. That's a learning process, right? That's an introduction to say, okay, here are the group of primary care DPC doctors around you. You need to stay relevant with them. The third thing I will always say is the specialists don't really know how difficult it is to market and build marketing programs. You have to be in front of somebody biweekly, or else people forget. So if you want to build up your referrals, you have to be sending them texts or postcards or whatever it is multiple times on an actual schedule or cadence. It's not enough just to send, your primary care colleagues a text message to say, hey, I'm open. I'm accepting dermatology referrals, whatever it is. You have to do that like weekly, or you have to do emails, and then you have to do phone calls. You have to stay relevant. So I would say those are the biggest three things that we find that specialists tend to struggle with.
Sure.
The whole field of dreams concept is a myth. Just because you build it, they will not come. You have to build it. You have to talk about it. You have to shout about it. You have to kind of be obnoxious about it, and then they will come.
Sure. So, it's funny. That was totally my experience also. My traditional referral base, when I opened up my practice, it just all dried up. I had referrals coming out my ears when I was working for the hospital system. And when I opened up my own practice, all of a sudden, everybody forgot who I was. And in my practice, interestingly, and I get asked about this when we go to the FMMA conference or wherever else, I get asked this question a lot by surgeons. And I tell them, and I'm curious to see if you've run across the same thing in the specialty practices that you've held. Where we had the greatest success in our marketing is direct to consumer. Trying to talk to doctors. Some doctors are going to be open to what I have to say. A lot of them, they just got blinders on. They've got tunnel vision, and they're like, if it's outside of my paradigm, then I don't have time to talk to you. What's been your experience in working with specialty practices?
As far as going direct to consumers? Yeah, it's needed. So from a multi-channel standpoint, we don't like to just say, hey, we're just going to target consumers or we're just going to target this over here. Every practice is different. If you're a OBGYN, you're opening up a new, GYN practice with no surgeries and no childbirth, it's a little bit different, right? Because it's not necessarily referral based. You're going to be going for something that is actually like creeping towards like primary care.
Sure.
And I don't say that in a bad way by any means. It's just most people think of primary as pediatrics, family, and internal, where a lot of women will only see their gynecologist, and that's the only doctor they ever see. So there is a lot of like primary care being practiced there. Totally agree with you. If you're something that's a little bit more advanced, so rheumatology, right? Not everybody's going to be like searching like I need a cash pay rheumatologist. A lot of specialties are steered by their primary care. And so I look at different specialties as kind of a spectrum, A to Z. If you got surgery as Z and you got A as a kind of the entry level, and say A is an urgent care or like primary care, right? Everything kind of goes along it. If you're an anesthesiologist, you're probably not going to be going direct to consumer unless you own a surgery center or something like that. But you're not going to say I'm going to build a direct to consumer anesthesiology practice. Probably be a little weird for a lot of people, but dermatology, yeah, that's a D2C, right? Or B2C, as I should say. Some of the examples I were using, but there are some other things like with cardiology, which is huge. So if there's any cardiologists listening right now, like we need cash pay cardiologists. I'll just put that out there in the universe, like big time. You'll have a lot of referrals from existing DPC practices, but there's always a mix, right? So we want you to have your brand so that people are aware of what you're doing so they can visit you on Facebook or social media. But where do we really want to put a lot of those advertising dollars? Who do we want to hit? And that's where that mix comes. And a lot of that is trial and error. It really is. I don't want to say that as coming across as like, hey, we're going to take all your money and then we're going to do all these different experiments with it. We're able to build on programs that we've done in the past and take a look and say, yeah, this worked, this didn't work, let's try this, not this. And then we experiment quickly if and when that time comes. But I guess the bottom line is my answer is like, it totally depends. And I hate saying that, but like that is like my most popular answer of all times. It depends what you're doing and really what you want to go and who you want to see. Like, who's your target patient? Do you want to do a membership or you just want to do, like I said, like second opinions? Do you want to see casework? All these things are kind of fun little problems to solve. But there's no one size fits all program by any means.
Sure. So as we finish up here, Chris, I have 2 questions for you that I ask every single one of our guests. First one, given that, a large number of our audience are medical students, residents, fellows, and people who are fresh out of training, what is the single most important takeaway message you have for them? The people who are, the world is their oyster and they're getting ready to jump into something or they just recently did. What's the advice you have for them?
Make sure you read any hospital or employment agreement and don't sign the first one. You can negotiate and you do have options. The biggest thing is if you ever see a non-compete, just tell them to take it out.
Run.
Yes. Yeah. Run. Go the other way. Absolutely. Awesome. Yeah. Read contracts. I mean, that's what you got to do. You've got to read everything. Don't just sign it and then build a budget and don't just go out and buy new cars and buy new houses now that you have an income. That's a great way to dig a very big hole that you may not get out of a long time, if ever.
Sure. And then the second question, how do people find you?
Visit freedomhealthworks.com. Easiest thing to do there. All of our programs are on there. All of our pricing's on there. So it kind of shocks people that we put our pricing online. And I say, well, I ask my clients to put their prices online, so I better damn well to do the same thing. It has links to our podcast up there too. So I appreciate you giving us a shout out there. There's a lot of great people, in this industry, which is fun. And I will say this, like if you're listening and you think, hey, independent medicine, business ownership's not right for me. We do have a clinical side of our company that is hiring great physicians. We're in Indiana right now looking to expand. So, if that's ever an option, we want to make it as friendly of a welcome into this industry as possible. And everybody's scenario is just a little bit different. So if business ownership's not appealing, then, there are a lot of very successful practices and groups, that will hire you on and build kind of succession planning with, other doctors and, kind of like a weird, kind of like an apprentice program, which is fun because I would say, like, from my standpoint, my parents are in their 70s now. They are just desperate for young physicians to come in, learn from them, learn 40 years of medical experience and take over panels. And there's a lot of physicians like that. So it's kind of fun to be able to problem solve different things on a day in, day out basis.
Sure. That's awesome. Any other last thoughts you want to share with everybody before we finish up here?
I think the big takeaway, man, is that, doctors have a choice. Doctors have been in control. we need doctors to take the lead again. If you're working in a group and you feel like they're just coming down, top down on you and not supporting you, give us a call. We'd love to chat and kind of see where you want to go. It's a big world out there. You deserve to be happy, I guess, is the easiest thing. And you deserve to take care of patients the way that you know how and the way that you were trained. So that's what it's all about. I think medicine's not a career, it's a calling. And if you're not feeling fulfilled in that calling, then you can make a change.
Awesome. Well, thank you, Chris, for being a guest on our podcast. It was very exciting having you on board, and it was really informative. I think I might have a few people I might just want to send your way. But it's been awesome having you on board. We've been trying to coordinate this for a while, and I'm so grateful that you've been patient with the process. And I think all our listeners will agree it was definitely worth the wait. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.